All right, I'm gonna go ahead and get started. Hello, everyone, and welcome to the Neurocritical Care Society Pharmacy Section Journal Club webcast. My name is Abdallah Amar. I'm a neurocritical care pharmacist at New York Presbyterian Weill Cornell campus, and I'm one of the moderators for today's session. We also have other moderators. We have Sarah Jung. She is a clinical pharmacist from Wellstar Keystone Regional Medical Center, along with Andy Webb from Mass General Hospital. We are excited to be presenting two articles for you today. But before we get started, I just want to make sure that everybody take a moment and make sure their mics are muted. We will be having a Q&A session at the end of each presentation. So feel free to post your questions in the chat section of the Zoom, or you can actually unmute yourself and ask the presenters your question at the end of their presentation. Make sure you're following us on Twitter under the Twitter handle of NCS PharmJC. Again, that's NCS PharmJC. Now, I would like to introduce our first speaker. Our first speaker is Renee McTee. She's a PGY2 critical care resident from University Hospitals Cleveland Medical Center in Cleveland, Ohio. And she will be presenting the title of the article is valproic acid as adjunct treatment for convulsive status epilepticus, which was published in Critical Care. Now I'll turn things to Renee. If you want to, I'll stop sharing my screen. You can share your screen.
Okay, thank you. Are you able to see my screen?
Yes.
All right, great. Thank you for the introduction, and thank you all for attending. Again, I will be presenting on the article valproic acid as adjuvant treatment for convulsive status epilepticus. To get started, I have a few objectives. So by the end of this presentation, I hope you will be able to describe the criteria to diagnose status epilepticus, identify current therapies that we utilize for convulsive status epilepticus, as well as tying everything together at the end and being able to apply the results of this trial to clinical practice. To begin, I want to briefly go over the pathophysiology of status epilepticus, as it is quite complex. So the whole cycle starts with some sort of aggravating factor. It could be as simple as a patient being not adherent with their medications or a whole trauma. And due to this aggravating factor, we get a loss of GABA-mediated inhibition. GABA is an inhibitory neurotransmitter that plays a part in controlling all the excitatory signals in the brain. And so when we have that loss, we further perpetuate seizures. Next, we have AMPA and NMDA, and those receptors will move to the synaptic membrane, and this causes additional excitatory action. Thereafter, we move through hippocampal sclerosis and then have an increased expression of various tachykinins. As you progress through this cycle, you will actually have increased pharmacoresistance. And the reason that we have so much research regarding this is that these patients become more and more resistant to our therapies as they progress and continue through this cycle. So we have a lot of patients that require multiple anti-epileptic medications just to control their seizures. Status epilepticus is a medical emergency. Historically, it was treated when a seizure was lasting more than 30 minutes, but this has fallen to the wayside as we now treat much earlier for better outcomes. So we treat when a patient has had a seizure that has lasted for longer than 5 minutes, or if they have 2 or more seizures and do not regain full consciousness between the different seizures. It's important to start timely treatment as represented by our guidelines, which I will get into in just one moment. And this is because patients that have a seizure lasting at least 5 minutes are likely to be prolonged. And as we just mentioned in the last slide, as you continue to progress through that cycle, they'll be harder and harder to treat. Within the first phase of these outlined phases in the guidelines, we have our stabilization phase, and this is represented by the first 5 minutes of a seizure. In this phase, we really make sure that the patient is safe and make sure the patient has a protected airway, their breathing is good, and their circulation is adequate. We want to make sure we're monitoring vital signs and preparing for it to possibly be prolonged into status epilepticus and needing further therapies. And so IV access is very important. Once a patient has had a seizure for at least 5 minutes, they move on into the initial therapy phase. And at this point, the guidelines recommend the use of a benzodiazepine. So we have intramuscular midazolam, intravenous lorazepam, or intravenous diazepam at this point. And these are used to completely abort seizures. If a patient is continuing to seize and it has lasted for at least 20 minutes, they move on into the second therapy phase. And this is when the guidelines recommend an IV loading dose of a few different antiepileptics. First, we have fosphenytoin, followed by valproic acid and levetiracetam. I do want to note that the guidelines don't recommend one treatment over another. It really is specific to the provider, specific to the patient, and specific to the institution. None have been proven to show superiority. After that, the patients progress into the third therapy phase, which is characterized by 40 to 60 minutes after seizure onset. And at this point, we really don't have great evidence to guide therapy. At this point, it's really up to the team to see how the patient is responding to various treatments and continue to add adjuncts until we can control their seizures. I want to highlight a couple different studies that have come out prior to the study I will be talking about today that are similar and have outcomes that we can analyze. The first one is the management of generalized convulsive status epilepticus, which was released in 2015. This was a prospective randomized controlled single center trial, and this looked at patients with generalized convulsive status epilepticus, which is similar to the patient population of the trial that I will be talking about today. These patients were into 3 different groups, and these different groups were characterized by different regimens with different order of those recommended therapies. So between phenytoin, valproic acid, and levetiracetam, they decided to look at different orders and see if we could find better outcomes for a specific order of using those medications. The primary outcome was control of seizures without recurrence with each addition of medication. I think the best way to look at the outcomes is through this flow chart that is provided in the article. So looking at the first group, which had phenytoin to start, followed by valproic acid, followed by levetiracetam, you can see the boxes with C, meaning those patients were controlled and their seizures were aborted properly, or the boxes of NC, which are the patients that were not controlled and had to progress to different therapies. So as you can see in this box, by the end of this regimen, the patients were largely controlled in their seizures, except for one patient that had to go on to further management. In the second group, we have valproic acid to start, followed by phenytoin, followed by levetiracetam. And these patients were largely controlled as well, with only 3 progressing to further therapy. And finally, our levetiracetam group had phenytoin added as the second adjunct, and then valproic acid as the final adjunct. Similarly to the last group, there were 3 patients that were uncontrolled by the end of this sequence. With all of this being said, and with statistical analysis, we did find that there was no difference in the treatment efficacy between any of these different regimens. So at this point, it really reinforces that we can utilize any of these regimens in any order that we expect to see them in, and it was still adequate therapy. The next trial is the ESET trial, which is a little more popular. This is by Kapur and colleagues, and this was back in 2019. This was a prospective randomized blinded multi-center study, so very well designed. And this looked at patients 2 years and older with generalized convulsive status epilepticus as well. Again, this is looking at our 3 key drugs, levetiracetam, fosphenytoin, and valproic acid. But patients had to have had a proper dose of benzodiazepine prior to using these medications. So patients were randomized into one of those 3 groups, and the primary outcome was absence of clinically apparent seizures and improving responsiveness at 60 minutes after the start of whichever trial drug they were randomized to. The outcomes, again, similar to the last trial, were very similar between the 3 groups. So if you'd rather look at it in a table format or a graph, I have provided both, just to really show you that there was no superiority between any of the 3 regimens. So once again, given everything, the statistical analysis, we found that there was no significant difference in the treatment efficacy. So you kind of see a trend here, as the literature hasn't really shown one profoundly amazing therapy that we should use first. And so this really posed this question for the trial I'll be discussing today: does the addition of valproic acid to the guideline recommended stepwise therapy improve outcomes in newly established generalized convulsive status epilepticus? The trial I'll be talking about today is valproic acid as adjuvant treatment for convulsive status epilepticus, a randomized clinical trial, which they also called the VALS trial. I want to start by going through the methodology of this study. It was a multi-center randomized double-blind placebo-controlled trial, so it is the gold standard of what we do prefer in our trials. Patients were randomized in a 1-to-1 ratio to either valproic acid or placebo as third-line therapy. The different strata were site, age, and presence of acute brain injury. And then the intervention dosing was valproic acid at a dose of 30 milligram per kilogram over 15 minutes, followed by a continuous infusion of 1 milligram per kilogram per hour over 12 hours. The placebo was administered identically, just using saline instead of actual drug. For patient selection, patients were included if they had generalized convulsive status epilepticus, they had to have been treated in an ICU, and they had to have had at least one anti-epileptic medication that had already been started within 6 hours prior to inclusion in this study. The major exclusion criteria noted in the study were non-convulsive status epilepticus, post-anoxic status epilepticus, any valproic acid that was administered prior to randomization into this trial, and then if a patient had any contraindications to valproic acid, such as hepatitis. I do want to note that there were some other exclusion criteria provided in this trial as an extended list, and a couple I want to bring to your attention that I will address later include hospitalization from any disease state with an expected hospital length of stay of greater than 15 days. Those patients were excluded, as well as any patient that had an expected ICU length of stay of less than 12 hours. The primary outcome of this trial was proportion of living patients discharged from the hospital at day 15. And then the secondary outcomes were recurrence of seizure while they were in the ICU, occurrence of refractory or super refractory generalized convulsive status epilepticus during their ICU stay, occurrence of inpatient adverse events, which they looked at all different grades of adverse events, cognitive status at day 90, which they mainly used the Glasgow Outcome Scale Extended, and then 90-day mortality. For a statistical analysis of this trial, it was powered to detect an absolute increase of 20% of patients discharged at day 15 in the treatment arm with valproic acid. The power was set at 90% with a two-sided alpha of 0.05. And this was all assuming a 50% rate in the control group, and if there were to be 124 patients per group. Of note, they did aim to recruit 150 patients per group just to account for various errors. They utilized an intention to treat protocol, and binary outcomes used the log binomial model, which was adjusted for the different strata. Time to event data were analyzed using either the Cox regression model or Fine-Gray regression model to account for variables, and this was all dependent on patient outcome. So now to get into the results of this study. Baseline characteristics: the majority of patients were male and aged between 55 and 60. Between acute brain injury, seizure type, and focal neurological signs, the groups did differ quite a bit. Unfortunately, there were no p-values to really tell if this was a significant difference, but there was some variability between the two groups in those sections. I want to draw your attention to second-line anti-epileptic. They had phenobarbital, levetiracetam, and fosphenytoin/phenytoin as their three options. And I just want to let you know this was because they follow different guidelines. This is a French study, and the French guidelines recommend those as your second-line anti-epileptics. But I think it's worth noting that fosphenytoin was utilized more often than either phenobarb or levetiracetam. Finally, sedation was utilized in many of the patients. Midazolam, propofol, and sodium thiopental were all utilized. And I think this really can affect the outcome, so that's just something to be aware of. So the results of the primary outcome, which is proportion of living patients discharged from the hospital at day 15, was the exact same between the two groups. As you can see, they did not reach their recruitment goal of 150 in each group. They had 126 patients in the valproic acid arm and 118 patients in the placebo arm. So it did yield an exact same percentage for the primary outcome, which had a p-value of 0.58, with that not being statistically significant. They ended the trial early, and that's why they did not get the recruitment that they desired. They were having difficulties with finding patients that met their criteria. For secondary outcomes, the only statistically significant outcome was recurrence of seizure during their ICU stay, as that happened in 12% of the placebo group and 6% of the valproic acid group. And so the p-value for that was 0.049. So it does meet statistical significance, with valproic acid having less recurrence of seizures. Occurrence of refractory and super-refractory status epilepticus during the ICU stay were similar between the two groups, as well as occurrence of inpatient adverse events of any kind. And I think this really tells you that valproic acid was generally well tolerated in this patient population. Cognitive status at day 90 via the Glasgow Outcomes Scale Extended was very similar between the two groups. And then finally, 90-day mortality, once again, did not differ between placebo and valproic acid. The author's conclusion was, with the administration of valproic acid, it was all very well tolerated by the patients and not associated with a significant impact on hospital discharge or the evolution into refractoriness in these ICU patients with generalized convulsive status epilepticus. They utilized the guidelines and followed them very closely, and they felt as though that patients had better outcomes when following very closely the guideline-driven care. Next, I want to go into the critique, and I will start with the strengths of the study. It was a multi-center, randomized, placebo-controlled, double-blind trial. And so this is our gold standard and really maximizes the applicability to the outside world and strengthens that external validity. I felt as though the major inclusion and exclusion criteria were very good, with including the maximum amount of patients with limiting confounding variables. I do want to note that the small exclusion criteria that they had mentioned secondarily, I do not feel fits in the strengths, and I will talk about on the next slide, but I think the major ones maximize this applicability to these patients. They utilize an intention to treat protocol, which again maximizes their external validity and gives it our real world applicability. Next, I want to discuss the limitations. First, the primary outcome. I feel it doesn't properly assess valproic acid as an efficacious medication. I think a more appropriate outcome could have been control of seizures at a given time point, or if there was need for additional medication to control seizures. A big one was that they utilized different guidelines, which they utilized the 2009 French guidelines, which are very different from what we use to practice in the United States. First line benzodiazepines utilized in the French guidelines are diazepam and clonazepam. They did not reference which patients got which medication. All of they said was that 93% of the groups received a benzodiazepine. Next, dosing and regimen differences. There were no other dosing listed besides the valproic acid, so we can't really tell if any of the anti-epileptics used prior to valproic acid were controlling the seizures because they were properly dosed, or if we could have really maximized those doses and had better patient outcomes. Again, we don't really see continuous infusion of valproic acid utilized in the United States. It's usually the intermittent infusions. So this is another difference between common practice here. Other anti-epileptic drugs and sedation drugs were utilized per physician discretion. And I think this really opens the door to confounding variables. So they were able to select any anti-epileptic that they wanted to use, again, without listing the dosing strategies utilized. And then my bigger concern is that sedation, a lot of patients, actually 1/3 of patients were on sedation prior to their arrival in the ICU. And so the sedation, as we know, in a lot of cases, we're already helping these patients to suppress these seizures. And sedation was utilized not only for refractoriness of status epilepticus, but also for other reasons such as agitation or vent dysynchrony. This study, again, had to abort the study early, and instead they did not meet power, unfortunately, so the statistical analysis isn't very strong in this case. The baseline characteristics did differ a little bit between groups. Unfortunately, we can't really tell if it was statistically significant, but I don't think that's a fault of the authors, as I recently learned that it is actually against French law to put statistics in baseline characteristics, so you will never find them in any French studies. Next, the patient had a generally shorter length of stay and a less mortality than our standard convulsive status epilepticus patients that we typically see. And so I think this is secondary to those exclusion criteria that were really limiting the patients that were sicker. And so we had a healthier cohort. Finally, there was a 6-hour lag time to therapy. And so I think that in waiting 6 hours to start the third line valproic acid, I think this could have resulted in a delay of care and possibly worsened outcomes. It's not something we can say for certain, but something we definitely want to keep in mind. So my conclusion of this trial, I think there were plenty of strengths and limitations to consider, but I think the limitations of the study, such as dosing regimens, confounding variables, and the time to intervention, really limit the generalizability and applicability of the results into patient care. At this point, with all things considered, I don't think there will be any change in practice indicated without confirmation by a large randomized controlled trial. But I do think it's still valuable to have this study, as it's something to really propel us forward into studying something else. So there was a lot of information within this study, a lot of layers to it. I do want to list some key takeaways and really summarize this so you can take it and form your own opinion. Data to guide stepwise therapy of additional anti-epileptic agents in convulsive status epilepticus is very limited. And there is continuous research out there to look more into it, see if there is any superiority for any drugs. But to this point, it's still the option open of the 3 medications that I had listed earlier. The addition of IV valproic acid is guideline recommended as an option for continued seizure activity, but you had to have had a benzodiazepine administration with appropriate dosing. In this study, IV valproic acid did not show improved outcomes versus placebo when utilized as the third line for generalized convulsive status epilepticus. But I do want to point out that there were confounding variables, and I don't think that the study was strong enough to really change practice. With all of that being said, I think it still warrants a large randomized controlled trial to determine the sequence of anti-epileptic drug additions. With that being said, I thank you for your time, and I would be happy to answer any questions you may have.
Well, thank you, Renee, for your presentation. Everyone feel free to post your questions in the chat, or you can unmute yourself and ask Renee your question. While people are actually posting their questions, I can ask the first question. So in general, when valproic acid being administered, usually we monitor valproic acid levels, total or free levels, through trough at steady state. In this trial, did the authors, did they monitor any valproic acid levels, and did they discuss any goals that they were aiming for these patients with convulsive status epilepticus?
Yes, they did measure levels, but it was in less than 10% of the patients. So the applicability of it is a little bit, I guess, a little spotty. They did measure levels prior to each administration, 15 minutes after the administration, as well as 12 hours after. So they did collect those on less than 10% of the patients. They did not put that in the supplementary appendix or anything, but I don't think it's a huge limitation, as those levels aren't as helpful when the patient is in status epilepticus.
All right, I don't see any questions in the chat. Out of curiosity, did the authors discuss why they were administering IV valproate as a continuous infusion? I don't know if it's a clinical practice in France, or is there any data for, or if you did you see any studies where they gave valproic acid as a continuous infusion?
I know, I found that very interesting, as it's really something I've never seen as practice here. They didn't mention their rationale with how they were dosing their valproic acid, but it's not standard practice. There are some studies that outline the continuous infusion, but there hasn't really been superiority proven with that versus intermittent. So I really think that it's just a regional change in practice.
Does anybody else have questions for Renee? All right, we can move to our next speaker. Our next speaker for today is Madeline Wickham. Madeline is a PGY2 critical care pharmacy resident from Novant Health Forest Medical Center. She will be presenting the effect of argatroban plus intravenous alteplase versus intravenous alteplase alone on neurologic function in patients with acute ischemic stroke, the ARISE trial, I believe. Madeline, you can start presenting.
Fantastic. Thank you so much for that introduction. Thank you so much for everyone for being here today. So I will be presenting to you the ARISE trial this afternoon. Our 2019 American Heart Association and American Stroke Association guidelines for the early management of patients with acute ischemic stroke recommend IV thrombolytic therapy and endovascular thrombectomy for reperfusion strategies in our acute ischemic stroke patients. They further recommend IV alteplase in select patients within 4.5 hours of stroke symptom onset or last known well. And additionally, they, at this point in 2019, have stated that the usefulness of argatroban, dabigatran, or other thrombin inhibitors has not been well established in patients with acute ischemic stroke, and therefore they do not have any current guideline recommendations for these agents. So moving into some of the literature up until this point, the argatroban anticoagulation in patients with acute ischemic stroke, or ARGUS-1 trial, was a multi-center randomized double-blind placebo-controlled trial. Patients were treated with either high or low dose argatroban as compared with placebo, and treatment was started within 12 hours of symptom onset. Overall, they included 171 patients aged 18 to 85. And again, they were presented within that 12-hour window from their symptom onset. Of note, they did exclude patients who met criteria for thrombolytic therapy, and therefore all of the patients included in the study were presenting outside of, at that point, the 3-hour window. Additionally, they excluded patients with intracranial hemorrhage, rapid symptom improvement, or any contraindication to anticoagulation therapy. Overall, they saw no difference in rates of symptomatic ICH at 30 days in occurrence of patients that received argatroban compared to placebo. So overall, this did show some promising safety outcomes, at which time led us to wanting further investigation. So next we'll go into the ARTS-2 trial, or argatroban with recombinant tissue plasminogen activator for acute ischemic stroke. This was a multi-center randomized blinded outcome evaluation exploratory trial that was conducted in both the US and the UK. They looked at TPA alone versus TPA plus low dose argatroban, or TPA plus high dose argatroban. Ultimately, they included patients within 4.5 hours of stroke symptom onset who were greater than 18 years of age, and with an NIH stroke scale of greater than 10, or any NIH stroke scale with a large vessel occlusion. And they excluded patients who were planned to receive endovascular therapy. So TPA plus argatroban was not associated with an increased risk of symptomatic ICH in these patients. Overall, the rates were very similar between groups. Additionally, rates of modified Rankin score of 0 to 1 at 90 days among patients receiving the combination therapy in either dosage was not statistically significant, with a relative risk of 1.34. It was 21% in the TPA alone group versus 30 to 32% in the combination groups. Finally, the safety and feasibility of argatroban and recombinant TPA and intra-arterial therapy in stroke, or ARTS-AI study, was a single-arm safety and feasibility study which looked at argatroban plus TPA plus intra-arterial therapy in stroke. This was attempting to determine if including our large vessel occlusion patients undergoing endovascular therapy was safe and feasible on a larger scale. So they included 10 patients with a initial argatroban bolus of 100 micrograms per kilogram, and then a 3 microgram per kilogram per minute infusion for 12 hours. And that was done within 6 hours of stroke onset. Then they went to endovascular therapy. Overall, they had no reports of symptomatic ICH. They had 2 asymptomatic ICH events, and overall patients achieved 60% of patients achieved a modified Rankin score of 0 to 2 at 90 days. Overall, promising results here as far as potentially being safe, but ultimately still lacking some larger trials with the consideration for this combination therapy and endovascular therapy. So overall, TPA monotherapy has shown many benefits in acute ischemic stroke, as we well know, including 20 to 30% of patients achieving complete recanalization, 60% achieving partial recanalization, and 34% of those potentially experiencing reocclusion with any form of recanalization. Additionally, there was a small Japanese study in 1997 that showed neurologic improvement with argatroban monotherapy given within 48 hours of stroke symptom onset. And based on previous trials, it does not appear that it necessarily increases the risk of symptomatic ICH in these patients. So the potential benefit thought with argatroban is the thought that being thrombin selective will enhance our effects of TPA, increase the speed and completeness of recanalization, prevent reocclusion, and improve the no reflow in microcirculation or failed restoration of microcirculation despite recanalization, and possibly provide some neuroprotection that was shown in rodent models within as given within 3 hours of stroke onset. Additionally, as I mentioned previously, there is still a clinical gap regarding the efficacy of thrombolytic therapy in combination with argatroban in patients undergoing endovascular therapy at this point. So that will bring us to our trial today, which is the effect of argatroban plus intravenous alteplase versus intravenous alteplase alone on neurologic function in patients with acute ischemic stroke, or the ARISE trial that was published in JAMA this year. The purpose of this study was to assess the efficacy of argatroban on neurologic function in patients with acute ischemic stroke who received IV alteplase. This was a multi-center, open-label, blinded endpoint randomized trial that was conducted in 50 hospitals in China from January 2019 to October 2021. Patients were included with acute ischemic stroke that presented within 4.5 hours of symptom onset, and were further randomized to argatroban plus IV alteplase versus IV alteplase alone. Overall, they included patients age 18 to 80 years old with an NIH stroke scale of greater than or equal to 6, and patients who were willing to consent to being part of the study. They did have rather large exclusion criteria, but I think our important pieces here is they excluded patients with a modified Rankin scale of greater than or equal to 2 at baseline. And the bulk of the remaining exclusion criteria listed here would be our traditional TPA exclusion criteria. Some additional methods: independent data monitoring and quality control committee was established at a central location, which helped with their overall process for this trial. They did complete block randomization with a block size of 4 through a computer generated sequence at the central location, which was then transmitted to the sites, and study team members were blinded to treatment randomization. So looking into our treatment groups overall, both groups received Alteplase at a dose of 0.9 milligrams per kilogram. This was given as a 10% bolus, and then the remaining was infused over 1 hour with a maximum dose of 90 milligrams. For our argatroban dosing, they were given a 100 microgram per kilogram bolus over 3 to 5 minutes within 1 hour of the Alteplase bolus. Patients were then started on an argatroban infusion of starting out 1 microgram per kilogram per minute for 48 hours with a target APTT of 1.75 times their baseline. Additionally, argatroban was monitored by APTT at baseline and then at 2, 4, 6, 12, 24, and 48 hours after initiation. There was additional monitoring within 2 to 4 hours after any dose adjustment, so any subtherapeutic or supratherapeutic APTT level. And then investigators were able to terminate the argatroban therapy if any major bleeding or symptomatic ICH was suspected. The primary efficacy outcome was the proportion of patients with a modified Rankin score of 0 to 1 at 90 days. Additional secondary efficacy outcomes included a modified Rankin score of 0 to 2 at 90 days, the proportion of patients with early neurologic improvement or deterioration at 48 hours, the NIH stroke scale change at 14 days relative to the randomization scores, and then any stroke or vascular event within the 90-day period. Additionally, they looked at adverse event outcomes, including the proportion of patients with symptomatic ICH, parenchymal hematoma type 2, or major systemic bleeding. Additionally, some clinical assessments: they did their NIH stroke scales at baseline at 24 and 48 hours, as well as 7 and 14 days from randomization. And then additional follow-up data were collected at 7 and 14 days unless they were discharged prior to, and then at 90 days after randomization. Baseline and follow-up NIH stroke scales were evaluated by the same certified neurologist. However, this neurologist was unblinded due to difficulty of blinding the open label argatroban in the study. Further, they did central adjudication for all clinical outcomes, and adverse effects were performed by blinded assessors. As far as sample size and power calculation, their goal was to enroll 808 patients, or 404 patients per group, to provide a power of more than 80% to detect a 9% greater difference in the primary outcome for the combination treatment group. This difference was based on the ARTS-2 trial, which we discussed or Bradley went over earlier, and they calculated a two-sided alpha of 0.05. Additionally, they assumed roughly 10% loss to follow-up. As far as the statistical analyses, they used a generalized linear model, which is similar to a linear regression model, but there's the potential for exponential response variables as opposed to a normal distribution, which is something I had never really experienced before with statistics. Additionally, they used this model for some of their secondary outcomes and used shift analysis and Cox regression models as appropriate. Overall, I believe these were reasonable statistical tests to complete for this trial. Overall, 817 patients were initially randomized, with 364 included in the full analysis set for the argatroban plus Alteplase group. and 396 were included in the Alteplase monotherapy group. On the right-hand side, I've included any exclusion criteria that were met for patients who were excluded from the study. Primarily, it was either patients that did not meet inclusion criteria or were outside of the window for TPA. For baseline characteristics, I have a few boxes highlighted here for you. The study was primarily male with 68 to 73% included. Average age was around 65 years of age. Our baseline NIH stroke scales at randomization were 9, and our baseline modified Rankin scores of 1 were in roughly less than 20% of our patients. Additionally, I did highlight the incidence of atrial fibrillation in these patients because I thought that it seemed much lower than what I've seen in clinical practice at about 5% between groups. Most patients had an undetermined cause for stroke, which I also thought was interesting, about 65 to 70% of patients. And overall, at the bottom, they had very low rates of endovascular treatment that was reported between 2 and 3% between groups. The researchers did note that not all sites had the capabilities to perform endovascular intervention, and vessel imaging was not required to participate in the study. The primary outcome of a modified Rankin score of 0 to 1 at 90 days was achieved in 64% between groups with a not statistically significant p-value of 0.78. So no major difference between our combination therapy and our Alteplase therapy alone. For our secondary outcomes, I've listed them all here for you. No statistically significant differences in any of the secondary outcomes, including early neurologic improvement or deterioration at 48 hours. As far as adverse events, they did not provide any p-values for these, so it's unclear if there's any statistically significant difference between groups, but overall, very low rates of adverse events between groups. And then finally, I think it's important to highlight the argatroban therapy. As pharmacists, I think this is something that we really want to see in the primary study. And this was actually a piece in the supplemental index that was provided. So overall, patients were reported to be in target APTT range within 5 hours. 22.8% achieved a target APTT, again, which is the 1.75 times their baseline within the 2-hour window, which I felt was pretty low. Overall, the patients had a total of 14 hours of therapeutic argatroban therapy in a 48-hour window for which they were supposed to be therapeutic. And I thought it was interesting, but there seemed to be very minimal adjustments to argatroban reported. So roughly somewhere around 2 adjustments over the 48-hour period with a range of 1 to 3. So the authors concluded that argatroban plus IV Alteplase did not result in any significantly greater likelihood of excellent functional outcomes at 90 days. They did note that overall there was a small number of patients with large artery occlusion, about 21%, compared to previous trials, including the ARTS-2 and the ARTS-AI studies that have been conducted, and that they believed that this may have contributed to a lack of significant improvement in the treatment group. They did note that argatroban plus Alteplase did not result in any significant harm among patients with acute ischemic stroke, and further that this suggests there's safety and feasibility of anticoagulants after thrombolysis, which is outside of current guidelines. As far as some strengths of this study overall, I do think, it was one of our larger randomized control trials for this therapy with argatroban and thrombolytic therapy. I think it's good that they used block randomization to randomize patients as best they can. They did use appropriate covariate adjustments and post hoc analyses to try to improve their external validity, and overall, they did show lower rates of serious adverse events. As far as limitations for this study, I think the argatroban therapy in general, being out of therapeutic range for more than 50% of time with minimal adjustments to reach therapeutic range is a limitation here. I think it's difficult to discern if argatroban therapy would have a larger and still safe effect in this patient population if they were in therapeutic range for a longer period of time. Additionally, they did not use any tenecteplase therapy, which I believe at least our practice site, and I think a lot of practice sites in the US have really moved towards using tenecteplase therapy. So I'm interested to hear if anyone has any thoughts on whether we can draw conclusions regarding tenecteplase from this study, or if we need further data. They also used imputed data points, and if they were not recorded, I think that adds a little bit of bias just to kind of shift themselves towards improved outcomes, and they did not outline how many data points they had to impute. They did not adjust for multiple analyses overall. And finally, they had very low enrollment of large vessel occlusions. And so I think this trial doesn't necessarily add to our body of knowledge when considering endovascular therapy. As far as clinical application goes, they did have low rates of harm with the use of argatroban after alteplase therapy in acute ischemic stroke patients. However, since argatroban therapy was subtherapeutic, I think it's difficult to determine if safety can be achieved at therapeutic levels. And overall, I think larger randomized control trials are needed with higher rates of endovascular therapy patients included to determine the true impact based on our current clinical practices. Then finally, I'd like to go over an ongoing trial with a similar subject matter. I think this could potentially add to our body of knowledge. So this is the MOST trial, or the multi-arm optimization of stroke thrombolysis. And they're including patients who receive thrombolytics within 3 hours of symptom onset, followed by either a direct thrombin inhibitor or a GP2B3A infusion, and endovascular thrombectomy per usual care. So they're including both tenecteplase and alteplase patients, and then also looking at argatroban, eptifibatide, and placebo within 60 to 75 minutes of thrombolytic initiation. The dose of argatroban is similar to other trials we've seen with the more high dose infusion. The 100 micrograms per kilogram is the bolus with a 3 microgram per kilogram per minute infusion for 12 hours. And then the integralin dosing is 135 micrograms per kilogram as a bolus, followed by an infusion for 2 hours. Overall, they're targeting an enrollment of 1,200 patients. And it's my hope that in addition to previous trials, this will provide some more definitive evidence for the efficacy and safety of both direct thrombin inhibitors and potentially for 2B3A inhibitors after thrombolytic therapy. And with that, I'm happy to take any questions.
Thanks, Madeline, for your presentation. It's a very interesting trial. Everybody can feel free to post questions in the chat. A question that I had is the choice of the dosing that they use in this trial. You mentioned that there's a higher dose where they use the infusion at the 3 microgram per kilogram per minute. Did the authors discuss in their article the rationale for using the lower doses? And do you think it could have influenced the outcomes of this study?
Sure. I think overall, they didn't explicitly outline why they chose to use the lower dose starting at 1 microgram per kilogram per minute for the continuous argatroban infusion. But I definitely think based on their time in target range for the argatroban infusion, that it certainly influenced their overall therapeutic kind of value that argatroban brings to this study in the addition to IV alteplase. So I think it's my hope that in future trials, after seeing such a large trial with the lower dose, that we will lean towards somewhere in the middle or higher range for argatroban that we've seen in some of the earlier studies in hopes of really having that therapeutic benefit for the trial period.
Yeah, I agree. Perhaps if they used the higher dose, they might have achieved higher percentage of patients at the targeted PTTs, the time within the targeted ranges for the PTTs. I don't see any other questions, but I think the other question I had is, why do you think in this study, the ARISE study, compared to previous studies, we did not see the same outcomes? So previous studies, they showed the outcomes, higher percentage of functional benefit. What do you think the main differences between this trial and previous trials that might have resulted in lower numbers of functional benefits?
I think, and I kind of alluded to this a little bit. I think one of the biggest areas where we're still seeing some gap in clinical evidence is after patients are able to undergo thrombectomy. And I think that in this patient population specifically, and being in China and not requiring vessel imaging, I think it's difficult to know if there were potentially more thrombectomy candidates at some of these other sites that didn't complete vessel imaging or send patients to thrombectomy. So I think overall, in the context of this study, I think some of the limits to practice in their practice sites compared to the US may potentially leave some room for much to be desired with regards for further endovascular therapy.
And do you think there's any theoretical hypothesis or benefits from using argatroban in patients with large vessel occlusion patients compared to other types of acute ischemic stroke? Because in this trial, they had only 20% of the patients who ended up going to thrombectomy or had large vessel occlusions who might have benefit from using argatroban versus the other arm. Is there any hypothesis why it would be beneficial in LVOs?
I don't know that there's a specific additional benefit in LVOs, but I think it does allude to the mechanism a little bit, where having something else that is also clot kind of targeted, where thrombolytics are looking at fibrin and argatroban's looking at thrombin, potentially has some benefit for additional breakdown of clot before going to another procedure for our larger burden strokes.
And I think some of the hypothesis that the use of alteplase could be beneficial for small clots where alteplase itself can lyse the clots. However, with the use of another agents like argatroban, you can completely lyse the clots in LVOs where you have bigger blood clots. I don't see any other questions in the chat. I guess with this, I would like to thank our speakers for today, both Renee and Madeline. And thank you everyone for attending today's Journal Club. And we hope to see you in our next Journal Club in June of this year. Thank you, everyone.
Great presentations. Thank you.